This is chapter 13, BLS resuscitation. So as far as the principles of BLS, they were introduced in 1960. Since then, the plan for how to perform BLS has been reviewed and revised every 5 to 6 years. The most recent review was conducted by the International Liaison Committee of Resuscitation, or ILCOR. BLS is non-invasive emergency life-saving care that can be used to treat medical conditions, including airway obstruction, respiratory arrest, and cardiac arrest. It focuses on the ABCs, airway, breathing, and circulation. If the patient is in cardiac arrest, then it switches over to a CAB second cycle. CAB is circulation, airway, then breathing, because chest compressions are essential and must be started as quickly as possible. Only seconds should pass between the time you recognize that a patient needs BLS and the start of that treatment, because permanent brain damage is possible if the brain is without oxygen for more than 4 to 6 minutes. So time is absolutely critical when you're talking about CPR. 0 to 1 minute, you get cardiac irritability. 0 to 4, brain damage isn't likely, but once you get up to 4 to 6 minutes, brain damage is possible. 6 to 10 minutes, brain damage is very likely, and more than 10 minutes, you're going to get irreversible brain damage, and that's without oxygen. Now, the body does have a small store of oxygen when it goes down, so it's not 10 minutes after the person stops breathing, but it's pretty close to that. So we want to initiate CPR as quickly as possible. So cardiopulmonary resuscitation is CPR. It establishes circulation and artificial ventilation in a patient who is not breathing and has no pulse. Your CPR steps: restore circulation by performing high-quality chest compressions to circulate the blood. You're going to perform 30 high-quality compressions. You're going to then open the airway, restore breathing by providing rescue breaths, and you're going to administer 2 breaths while you visualize the chest for chest rise. And this continues to repeat 30 to 2, 30 to 2. So here's kind of what we're looking at. We've got somebody performing chest compressions, and we've got somebody performing airway management. BLS differs a lot from advanced life support, which involves advanced procedures. So ALS ends up bringing into consideration cardiac monitoring, administration of IV fluids or medications, use of airway adjuncts, but this isn't something that you can provide at your level of care. So that's why it's often necessary for you to call in additional resources to get ALS there. When done correctly, BLS can maintain life for a short period of time until ALS measures can be started. Oftentimes, it's going to be those ALS measures that's going to be life-saving. The system components of CPR: you've got the chain of survival. The American Heart Association's chain of survival is recognition and activation of the emergency response system, immediate high-quality CPR, rapid defibrillation, basic and advanced emergency medical services, and then advanced life support and post-arrest care. If any one of the links in the chain is absent, the patient is more likely to die. So getting advanced ALS called as soon as you recognize that you have a CPR type emergency is definitely critical. And here's this all over again, the same ones that we just seen on the previous slide. Assessing the need for BLS: always begin by surveying the scene. Always, always, always. This is nothing new. We've talked about this several times. You want to complete a primary assessment as soon as possible in order to evaluate the patient's airway, breathing, and circulation. First step is determining if the patient is responsive or not. If the patient is unresponsive, then you continue on in your assessment. If the patient is responsive, the patient does not need CPR. So a responsive patient is not going to need CPR. Everything is working just fine. This step should take no more than 10 seconds. The basic principles of BLS are the same for infants, children, and adults. Although cardiac arrest in adults usually occurs before respiratory arrest. The reverse is true in infants and children. So typically in infants and children, respiratory arrest is going to lead to cardiac arrest. So we want to fix the airway portion of that problem sooner in children and infants. And then in adults, it's the exact opposite. Cardiac comes first. So he's checking him for responsiveness, tapping and shouting, "Sir, sir, are you okay?" The automated external defibrillator. The AED is a vital link in the chain of survival. The AED should be applied to a cardiac arrest patient as soon as it's available. If you witness cardiac arrest, begin CPR and apply the AED as soon as available. AED use in children, you're going to apply after the first 5 cycles of CPR. So first with kids, we want to do CPR, and then we want to apply the defibrillator. For children 1 month to 1 year of age, a manual defibrillator is preferred. If this is not available, use pediatric-sized pads with a dose attenuator. It's this little box that's clipped onto the wiring. If neither is available, then use an AED with adult-sized pads with the anterior posterior placement. You want to make sure that those pads aren't touching each other. So putting one on the front and one on the back of the child is going to be necessary. Special situations. Pacemakers and implanted defibrillators place the electrode at least 1 inch away from the device. So these are typically up on the shoulder region, right below the collarbone. It's smaller than a deck of cards. If you feel one of these implanted devices, just don't put the pad directly over top of it. Put it 1 inch away. Wet patients, if the patient's in water, pull the patient out and dry the skin before attaching the AED pads. If the patient is in a small puddle of water or in snow, the AED can be used. Try and dry the patient's chest as much as possible, but a little bit of water is not going to hurt what you're doing. Transdermal medication patches, remove the patch and wipe the skin to remove any residue prior to attaching the AED pad. Make sure that you don't get it on your hands. How that medication goes into the patient is by absorption through the skin. So try and be as careful as possible when you're removing any sort of medication patches so that you don't touch it yourself and end up soaking that medication through your skin. Positioning the patient. For CPR to be effective, the patient must be lying supine or on their back on a flat, firm surface. Must be enough space around the patient for 2 rescuers to perform CPR. 2 rescuers is going to be your most efficient method for performing CPR, so you want to make sure you can get 2 people over to it. If possible, log roll the patient onto a long backboard. That makes sure that you have that hard surface behind the patient, and then it's easier to move them if you need to. If you have to move furniture out of the way, move furniture out of the way. If you need to pull the patient into a living room or a larger room, if they collapse between the bed and the wall and there's just not enough room to work, go ahead and move that patient as quickly as possible, but move the patient before so you can actually perform effective CPR. Checking for breathing and a pulse. Quickly check for breathing and a pulse. These assessments can occur simultaneously and take no longer than 10 seconds total. Visualize the chest for signs of breathing. Palpate for a carotid pulse. That's the one up in the neck. He's showing you here in the picture. If needed, call for help and an AED. Performing external chest compressions. Apply rhythmic pressure and relaxation to the lower half of the sternum. Sternum is that chest bone. Compressions squeeze the heart, acting as a pump to circulate the blood. It squeezes the heart between the sternum and the vertebrae in the back, trying to make sure that your heart continues moving blood throughout the body. Avoid leaning on the chest between chest compressions. You want to give it a chance to completely recoil or come back to a normal position. Proper hand position and compression technique. You're actually going to take the heel of one of your hands and put that over that lower half of the sternum. Then you interlace the fingers of your other hand on top, and you want to make sure that you're coming straight down on your hands with your elbows locked, and you're using not your arms to pump the chest. You're using your back muscles, your leg muscles, your butt muscles. Those are what you want to use, big muscle groups, to try and give really good chest compressions. Injuries can be minimized by proper technique and hand placement. So this is just showing you kind of proper positioning for the heart inside the body. This is showing you proper hand positioning when you're doing good chest compressions. You're completely pushing straight down through your arm, having your hands underneath of your shoulders so that you can actually give good chest compressions. When you're done pressing down all the way, you want to go ahead and let the chest recoil or come back to a normal physiologic level. This is showing how to open an airway. There's two different ways to open an airway. The head tilt chin lift maneuver is definitely the easier. This is putting a hand on the forehead and 2 fingers underneath the bony part of the lower jaw and tilting the head backwards. The other is the jaw thrust maneuver. You're putting your thumbs on top of the zygomatic arches or the big bones in your cheek, and the rest of the fingers behind the angle of the jaw and lifting forward. It's not as easy to perform. Somebody that's unconscious is a little bit easier to perform on, but it's harder to maintain because it does take a lot of hand strength to maintain this. This is going to be if you suspect somebody has trauma, you're going to use the jaw thrust maneuver rather than the head tilt chin lift. If you determine that a patient is breathing adequately on his or her own and has no signs of injury to the spine, place them in the recovery position. The recovery position is shown here. You pull one leg, the top leg, up into a bent position while you have the patient laying on one of their sides. You're going to put their hand underneath of their head so that if they end up vomiting, they don't end up choking on it. You don't want to leave them laying flat on their back. A lack of oxygen, also called hypoxia, combined with too much carbon dioxide in the blood or hypercarbia is lethal. You want to provide slow, deliberate ventilations that last 1 second, and this is if somebody is not breathing adequately. If the patient's not breathing, ventilations can be given by 1 or 2 EMS providers. Use a barrier device such as a pocket mask, a one-way valve, or a BVM. If the patient has a stoma, go ahead and place the BVM or pocket mask directly over the stoma. Artificial ventilation may result in gastric distension or the stomach being filled with air. If that happens, have a suction unit available because the patient is very likely to vomit. Here's showing proper placement of a BVM over a patient. Notice that the head is extended because he's got a couple of fingers there underneath the bony part of the jaw, lifting backwards so that the patient has an open airway as well as getting those good ventilations. Like I said, the patient's stomach is likely to fill with air if you're giving ventilation, so you want to make sure that you have your suction unit available. This is a stoma that's in the neck. You can see the hole there. If that patient has that, just go ahead and put the BVM or the mask right over top of that stoma and go ahead and deliver your ventilations. And we will go ahead and stop here.